Hello, my name is Amber Brandolino, and I'm from the Medical College of Wisconsin. Today, I'm going to discuss my community-driven Spanish translation of the Injured Trauma Survivor Screen. The Injured Trauma Survivor Screen, known by its short name, ITS, was developed by my mentor, Dr. Darun Cassini, and her mentee, Dr. Hunt. It is an inpatient risk prediction screen with good sensitivity and specificity for predicting the development of post-traumatic stress disorder, PTSD, and depression at 1 and 6 months post-traumatic injury. The ITS has 9 items and is administered by social work at our trauma center. Every yes to a question equals a score of 1. A sum of 2 or more for PTSD or depression indicates that the patient is risk positive. An important consideration for the theoretical framework guiding this translation is that there is no gold standard study design for translation studies. That is because each approach has strengths and weaknesses dependent on the time, personnel, and financial resources available for the project. I therefore elected to have participants forward translate the screen and then back translate. I broke down each screen item into its smallest grammatical unit. The frequency of each translation per unit was then tabulated. The goal was to use the most common translation of each item. An example is shown on the right side of the screen. This approach to data abstraction and analysis was chosen in order to offer a methodical stepwise translation that's centered on the participant's use of language. This would allow the translation to be driven by the bilingual community. For the forward translation phase, there were 10 participants from a local community clinic and 100 international participants from Amazon's MTurk platform. 5 pre-identified bilingual persons provided Spanish to English back translations off the aggregated forward translation. The end result was the final Spanish ITS. In both samples, participants were majority male, identified as Hispanic, Latinx, or white, had close to native English and native Spanish writing proficiency, and were largely from the United States, Mexico, Venezuela, Peru, and more. However, the MTurk group was younger, more highly educated, and with less years in the United States compared to the clinic group. From the forward translation, the most common translation of each question was used in the final screen draft, except on 4 occasions. These were issues of grammatical congruency or lack of clarity. In these cases, the next most common translation was then used. The most common pronoun used was the formal usted. However, participants interchangeably conjugated their verbs between the formal and informal use of you. Given the patient-provider relationship, the final screen uses the formal you. In the back translation phase, only 2 changes were made. These were because the back translation revealed a word choice in which the latent construct being measured in 2 questions was being named. A question about anxiety or nervousness or depression should not include those words within the questions themselves, as it may be leading. The resulting final version of the Spanish ITS comes from a methodical group approach to the translation of a pre-existing screen. It extends the clinical utility and availability of a PTSD and depression screen for use in trauma centers. It also eliminates the need for a medical interpreter to administer the screen. This makes it easier to embed the screen within clinical care in a standardized way. It also presents the opportunity for the ITS to be used in cross-cultural research. However, it must be considered that it will need validation at multiple centers, though it is currently being validated within our single center. The screen may also need to incorporate culturally specific items or regional language. Lastly, it will also require revision should the DSM-5 update PTSD or depression in its next edition. Thank you, and feel free to contact me with questions.